Yes, yes, sir. Three, two, one, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a class on Priapism, and this would be presented by our resident, Dr. Karan, and would be moderated by our faculty, Dr. Ajayraj. So I request Dr. Karan to kindly share his presentation.
Morning, respected teachers. Uh, my today's topic of presentation is priapism. Priapism is full or partial erection that continues for more than 4 hours beyond sexual stimulation and orgasm, or is unrelated to sexual stimulation. Uh, Classification of priapism: it's of three types: ischemic priapism, non-ischemic priapism, and stuttering priapism. Ischemic priapism, also known as veno-occlusive priapism or low-flow priapism. It is persistent erection marked by rigidity of corpora cavernosa. Ischemic, ischemic priapism is persistent erection marked by rigidity of corpora cavernosa and little or no cavernous arterial inflow. In ischemic priapism, there are time-dependent changes in corporal metabolic environment with progressive hypoxia, hypercarbia, and acidosis. Patient typically reports with penile pain after 4 to 6 to 8 hours, and examination reveals a rigid erection. It is an emergency. When left untreated, resolution may take days to weeks, and severe corporal fibrosis and erectile dysfunction results. Interventions beyond 36 hours of onset may help relieve pain and erection, but there is no preservation in potency. Stuttering priapism, also known as intermittent recurrent ischemic priapism. It is characterized by a pattern of recurrence. It is usually found in patients with sickle cell disease. Patients typically awaken with an erection that persists for several hours. Males with sickle cell disease may experience stuttering priapism from childhood. Any patient who has experienced an episode of ischemic priapism also at risk for stuttering priapism. Non-ischemic priapism. It is persistent erection caused by unregulated cavernous arterial inflow. Corpora are tumescent but not rigid, and penis is not painful. History of blunt trauma to perineum or iatrogenic needle injury is common. Injury results in disruption of cavernous arterial anatomy, creating an arteriosinusoidal fistula. The cavernous environment doesn't become hypoxic, ischemic, and blood gases don't show hypoxia, hypercarbia, or acidosis. Once properly diagnosed, it is not an emergency. Causes of priapism. Intracavernosal injections are one of the most common causes of priapism. Sickle cell disease, certain drugs, and recreational agents. These are certain drugs that may cause priapism, and certain neurogenic and neoplastic conditions can also cause priapism. And hematological conditions like sickle cell disease, thalassemia, leukemias, anti-anxiety agents, anticoagulants, antidepressants, antihypertensives, and recreational drugs like alcohol, cocaine, crack cocaine. Priapism in children. Priapism in children and adolescents is most commonly related to sickle cell disease. Other causes are polycythemia, blood transfusion, and birth canal trauma. Evaluation and diagnosis of priapism. First of all, we take history of priapism. We have to determine whether it is ischemic or non-ischemic. Ischemic priapism should be suspected when patient has progressive penile pain associated with duration of erection, has used a known drug with priapism, or has history of intracavernosal injections. Stuttering priapism history is recurrent episodes of prolonged erections, usually non-resolving morning erections. Non-ischemic priapism should be suspected when there is no pain and erection duration has not been accompanied with progressive discomfort. There is history of straddle injury, coital trauma, blunt trauma to penis or perineum, penile surgery, or a diagnostic procedure. Elements in taking history of priapism: duration of erection, presence of pain, previous episodes of priapism and method of treatment, baseline erectile function, use of any erectogenic therapies, medication and recreational drugs, sickle cell disease, hemoglobinopathies, hypocoagulable states, trauma to pelvis, perineum, or penis. Physical examination. In ischemic priapism, the corporal bodies will not be completely rigid. Glans penis and corpora spongiosum are not. If physical examination reveals penis to be non-tender, tumescent, or partially erect, non-ischemic priapism should be suspected. In non-ischemic priapism, corpora will be tumescent but not completely rigid. In children and adults with high flow priapism, depending upon location and of trauma, there may be residual bruising. Key findings seen in priapism. Perineal trauma is usually present in non-ischemic priapism. Hematological abnormalities are usually seen in ischemic priapism. Intercorporal injections are usually seen in ischemic priapism. Cavernosa is usually fully rigid in ischemic priapism, and penile pain is also present in ischemic priapism. Ischemic priapism also shows abnormal blood gas shadows, and on Doppler study, inflow is usually high in non-ischemic priapism. Laboratory testing, we generally do normal blood tests. In areas with sickle cell disease, we can do sickle cell screening. Corporal blood aspirate is done, and visual inspection of blood is done. It shows a crankcase oil appearance. On blood gas values, in ischemic priapism, the blood gas values are usually ischemic. PO2 is less than 30, PCO2 more than 60, and pH is acidic. Penile imaging, color Doppler ultrasound can be done. In ischemic priapism, there will be no blood flow in the cavernous arteries. In patients with non-ischemic priapism, they have normal to high blood flow velocities. This is the picture showing color Doppler ultrasound. MRI has 3 roles in imaging of priapism. A well-established arteriosinusoidal fistula can be seen. It can demonstrate the presence and extent of tissue thrombus and corporal smooth muscle infarction, or any corporal malignancy or metastasis can be seen. In this image, corporal malignancy can be seen. Treatment of priapism. First of all, medical treatment for ischemic priapism. Oral agents are not recommended in management of acute ischemic priapism. Cold compressions can be done. Patient can be asked to do exercises. Stebutyline can be used. Recommended initial treatment is decompression of cavernosa by aspiration. Aspiration should be repeated until no more dark blood can be seen coming out of the corpora and fresh bright red blood is obtained. This process leads to marked decrease in intercavernosal pressure, relieves pain, and resuscitates the corporal environment, removing anoxic, acidotic, and hypercarbonic blood. This is summary of treatment of ischemic priapism. First of all, history and physical examination is done. Diagnostic aspiration and penile blood gas and Doppler ultrasound is done, which shows ischemic priapism. And we evaluate for predisposing conditions, and diagnostic and therapeutic aspiration is done. Intercavernosal alpha-adrenergic injections can be used. Repeat aspiration is to be done, and BP and heart rate should be monitored. If it fails, then shunting procedures are done. And if they also fail, penile implants can be done, and erectile function outcomes should be documented. Corporal aspiration, if unsuccessful, should be followed by alpha-adrenergic injection or irrigation. Phenylephrine is agent of choice. It should be concentrated as 200 micrograms in normal saline and administered as 0.5 to 1 ml. Lower concentration should be seen in children and adults. Hypertensive stroke has been documented by use of phenylephrine. Structuring priapism. Limited daily administration of oral adrenergic should be considered in management of structuring priapism. Drug therapy is typically initiated at bedtime. Oral alpha-adrenergic administration is preventive strategy for structuring priapism. PDE5 inhibitors have also been used. Hormonal therapies can also be used in management of priapism. They target at the pituitary glands, GnRH and agonist, or by suppressing the pituitary function through feedback inhibition, blocking androgen receptors, reducing testicular and adrenal synthesis. Common goal of hormonal therapy in prevention of stuttering priapism is to reduce serum testosterone to hypogonadal levels. PDE5 inhibitors have also been used in management of stuttering priapism. When used in long-term regimens unassociated with erection stimulatory conditions, They alleviate the recurrent priapism episodes in men with sickle cell disease. Surgical management of ischemic priapism. Surgical management is indicated if after repeat penile aspirations and injections have failed, if such an attempt has resulted in significant cardiovascular side effect. Early surgical intervention may be preferable in patients with malignant or poorly controlled hypertension or men using MAO inhibitors who have contraindications to alpha adrenergic therapies. Shunting can be done for patients lasting priapism 72 hours or less. Objective of shunt surgery is reoxygenation of cavernous or smooth muscle. The principles of shunt surgery is to re-establish the corporal inflow by relieving the venous outflow obstruction. This requires creating a fistula between corpora cavernosa and glans penis, corpora cavernosa and corpora spongiosum, or corpora cavernosa and dorsal or saphenous veins. These are certain types of shunt procedures that are being used. Nowadays, open distal shunt, elbow rub, or corporal snake is used, and combined T shunt and corporal snake maneuver is being used. A distal cavernoglanular shunt should be first choice of shunting procedure because it is technically easier to perform than proximal shunting. Percutaneous distal shunting is less invasive than open distal shunting and can be performed with local anesthesia in emergency department. This photo shows a winter shunt in which distal cavernosal gland shunt procedure is created by transglandular placement of large hole needle. And picture B is corporal snake maneuver, which is a modification of Yadav shunt. This is Yadav shunt procedure, which requires excision of circular cone segments of distal tunica albuginea. Factors determining successful reversal of ischemic priapism are evacuation of thrombus, re-establishing cavernous inflow, and patency of shunt. How do we assess for patency of shunt? Visualization of bright red blood and corporal aspirate, corporal blood gas, color Doppler ultrasound, measurement of intercavernous pressure, and penile compression maneuver. Complications of shunting. These include penile edema, hematoma, infection, conversion of low flow to high flow fistula, urethral fistula, penile necrosis, and pulmonary embolism. Immediate implantation of penile prosthesis. Untreated priapism or priapism refractory to interventions leads to complete erectile dysfunctions and severe fibrosis and penile length loss. Advantages of early penile implantation in acute management of ischemic priapism are preservation of penile length and technically easier insertion. Delayed placement of penile prosthesis is technically challenging because of fibrosis. An MRI before surgery or biopsy should be done to document smooth muscle necrosis. There are higher complication rates in patients with priapism using penile implants. These include infection, urethral injury, device migration, device erosion, and need for revision surgeries. Management of non-ischemic priapism. Cold compressions can be used, perineal compression can be used, embolization, and surgical management. Interventional angiography and management of arterial priapism. In arterial priapism, arterial equina fistula is seen. Selective internal pudendal catheterization and subsequent embolization can be done. It can be done using various agents like microcoils, polyvinyl alcohol, and butyl cyanoacrylate, gel foam, autologous blood clot. The success rate is high, but however, there are reprocedures have to be done because there is high recurrence rate. And most common side effect is erectile dysfunction. This photo shows angioembolization of internal pudendal artery. Surgical management of arterial priapism. In cases of long-standing arterial priapism in which a pseudocapsule around the fistula has developed, surgical ligation has been reported to be successful. Formation of capsule may take weeks to months after trauma. Corporal exploration before formation of pseudocapsule may result in ligation of cavernous artery rather than selective ligation of fistula. This is a summary of treatment of arterial priapism. History and physical examination is done, and diagnostic aspiration is done, and which reveals a non-ischemic priapism. Active interventions like Doppler ultrasound and site-specific compression is done. Selective pudendal angiography and embolization can be done, and we have to document the erectile function results. If still there is priapism, then we can do AV fistula ligation.
Thank you, Karan, for the presentation. I think if you have any query or anything which you haven't understood, please let me know. Do we have any experts with us now? Dr. Joshi is. Okay. So if there is any kind of comment to be made by any faculty or resident who might have joined us today on Zoom, please let me know by raising your just hand. So what I will do is I will just kind of give you a brief synopsis. You have MCQs also, right? So after that, we will take up MCQs. So we all know Priapism is defined as is a prolonged erection, usually more than 4 hours, which is unrelated to appropriate stimulation, right? And the word comes from Priapus, is a word for Greek god of fertility and sexuality, right? So if you just see the picture of this Greek god who has a very long penis, right? And so Priapism comes from that word. And the incidence is around 0.5 to 1.5 per 100,000. When we talk about the types of Priapism, as he described, ischemic, non-ischemic, and stuttering or recurrent Priapism. There is another type of Priapism which may be considered as a prolonged erection, is called nocturnal painful erections sometimes. Sometimes patients will have nocturnal painful erections. That is also considered as a part of this prolonged erection. When we talk about the various causes, we know non-ischemic causes, about 2/3 of these patients are nowadays done because of intracorporeal injection of vasoactive drug. We know intracorporeal injection are being used for diagnostic penile Doppler study and also therapeutic home self-injection program for erectile dysfunction. So many of these patients can land up in Priapism. And that is probably 2/3 of these patients are probably due to this intracorporeal injection. And rest of them could be due to various other causes. As he described, it could be drug-induced. There are various drugs which can cause like trazodone, antipsychotics, right? Then cocaine and illicit drugs, or even alcohol, etc. So all this can cause. And the third important cause is the various type of blood dysplasias like hemoglobinopathies, sickle cell anemia, thalassemia, and kind of any state which causes a hypercoagulable state, right? Which results in kind of a blockage of these venous channels and cause erection. And the fourth cause is the malignancy. So malignancy, metastasis or infiltration from nearby malignancy into the penis can cause erection. So the common causes would be leukemia, melanoma, even carcinoma prostate, carcinoma bladder, renal cell carcinoma. All these can have metastasis or can cause infiltration into the penis. The pathophysiology behind this is that whenever there is such kind of a hypercoagulable state or there is an erection which remains for a prolonged period as it is in intracavernous injection, the venous channels gets blocked. As the venous channel will get blocked, there will be an erection, and slowly, because of the prolonged erection, there is a ischemia of the cavernous smooth muscles, right? Hypoxia, and they do not relax then. So if they do not contract, rather. So if they are not able to contract, this prolonged erection will continue, right? So that leads to Priapism. So this is what happens in ischemic Priapism. And non-ischemic Priapism, the main causes is injury. So either it could be a needle injury or it could be a blunt or penetrating injury to the penis or the perineal region, which produces an injury to the cavernosal artery in the penis, and it produces an arteriovenous fistula, which results in increased arterial inflow, but there is no venous blockage. So that's why there could be some kind of tumescence, but not rigid erection, and that will be not painful, right? So this results in a non-ischemic priapism. And stuttering or recurrent priapism is mainly due to sickle cell disease or some kind of a nitric oxide cyclic GMP pathway abnormalities. And that results in erections which are not actually priapism, but they are kind of erections, prolonged erections. And slowly this duration of prolonged erection may increase, and gradually they cause some degree of injury to the penis and results maybe in later part erectile dysfunction. So this was pathophysiology. So once a patient comes with priapism, this is a surgical emergency, right? In case of ischemic priapism. So we need to take a proper history of the patient, how long the duration of the priapism has been, whether it is painful or not painful, what was the cause behind it, whether there was an intracavernosal injections, whether there any history of drug intake, is there any history of malignancy, leukemia, sickle cell disease? So all this, if there is blood distillations, all this history has to be taken very properly to find out what could have been the cause for this priapism. So you do a physical examination of these patients. So in an ischemic priapism, they will have rigid erection with tender penis, right? And whereas in a non-ischemic priapism, it would be a kind of a tumescent penis, which is non-tender. And sometimes you can also palpate the bruit of the arteriovenous fissure in a non-ischemic priapism. Right? And then what about the investigations? Usually, ischemic priapism will be clinically diagnosed. You don't need any kind of investigation to diagnose a ischemic priapism. But the investigations which can be optional, you can do, or if you are not very confident of your diagnosis, then you can do some investigations, as I said, the corporal blood gas analysis, because in ischemic priapism, there is hypoxia, acidosis, and acidosis which causes pain. And so that results in some blood gas abnormalities. The pH becomes less than 7, the oxygen PO2 level goes less than 30, PCO2 goes more than 60. So this is ischemic priapism. So in non-ischemic priapism, usually the PO2 will be more than 90 and PCO2 will be less than 40 and pH will be around 7.4. So there will be no change in blood gas parameters. So this is a corporal blood gas analysis. So you can do a color Doppler study. Color Doppler study in ischemic priapism will show total loss of arterial inflow, and in non-ischemic priapism you can get an arteriovenous fissure, right, with increased arterial flow. So that will tell you about whether this is ischemic or non-ischemic priapism. Sometimes in very kind of complicated cases, particularly if they are associated with malignancy or all that, then you can do a MRI or a contrast-enhanced MRI to find out what is the cause for this priapism. Right. So this was about the evaluations. Now, how to treat these patients. So the first important thing is prophylaxis. So because the commonest cause is intracorporeal injection of vasoactive drug, it is very important that whenever this intracorporeal injection is given, you have to counsel the patient properly, right? You cannot allow the patient to go from the office when you're doing a benign Doppler study before the patient gets D-tuberculosis, right? So if you allow them to go, there is always a chance of developing a prolonged erection. So always give them a kind of a counseling proper. There is a priapism letter also. If suppose they develop kinds of priapism, what to do next, and give them a helpline number so that they can immediately contact you if they go into such kind of a prolonged erection. Very important. Otherwise, it's almost like a criminal negligence on part of the doctor. So because the patient will totally or lifelong become impotent. So that is very important. So prophylaxis is very important. So usually you would not allow the erection to continue for more than 1 hour. So if the erection continues for 1 to 2 hours, then what we do is we usually ask my own protocol for prolonged erection is that I would ask the patient to have a kind of a exercise. I would ask him to run for about 2-3 kilometers, and so that he just starts sweating, and that results in what? It results in a kind of a steal phenomenon. What is that steal phenomenon? Because the blood will go away from the penis and to the other parts of the body, which is exercising. So some cases may resolve after this kind of an exercise. Sometimes you give just a cold compressor kind of thing. That helps in kind of vasoconstriction, decrease arterial inflow, and may reduce the erection. And what I had did a study which is around 20 years ago, and which was published in the International Journal of Sexual Medicine, and it is cited in Campbell's Urology also, if you can just want to see, is the oral terbutaline. Oral terbutaline in the management of prolonged erection. So what I used to give oral terbutaline 15 milligram twice day, 15 milligram every 15 minutes. And that was done after 2 hours of erection. So many of the 1/3 of these patients will respond to such type of therapies. So oral terbutaline or oral pseudoephedrine, which is usually not available. So these drugs can help in patients for prolonged erection. If the erection goes more than 3 hours, try to inject a vasodilator. So diluted phenylephrine is the best drug, which is given in the dose of 250 to 500 microgram in a diluted manner. Or if it is not available, you can give diluted adrenaline. But it has to be under all kind of monitoring with BP, monitoring ECG. If the patient is hypertensive, you should not. If it has a cardiac issues, you should not give diluted. So don't allow the patient to go more than 4 hours, which is the definition of Priapism. So once it goes more than 4 hours, then definitely probably just simple injection of vasodilator drug or other therapies would not help, because the ischemia has set in. There is some kind of a corporal smooth muscle ischemia. They are not able to contract. So these things would not help even if you give a vasodilator drug. In that case, you need to aspirate. Aspirate the old blood in the corporal bodies and irrigate it with normal saline. Sometimes you use a heparinized normal saline. So if that helps, it okay. Otherwise, after irrigation, you will give a vasoactive injection drug. You have to give diluted phenylephrine solution and keep the penis compressed. So this can be done repeated, because many times what will happen, this will again cause recurrent erection. Once they get deuteromus, but still they, again, after a few minutes, they can again get erected. So you can do it 2 or 3 times, all right? Suppose the patient comes after maybe 24 hours or none of these happens. Then there is a process which is called extended cavernosal drainage. So in that, we usually put a butterfly 18 or 19 gauge in one of the corporal bodies and then allow the blood to drain out. So this can be continued for about 15-30 minutes, even 45 minutes. So once the old blood comes out and slowly the bright red blood starts coming, then the oxygenation of the penis starts happening, and there is less ischemia of the cavernosal smooth muscles, and they have some ability to contract. So this thing might help in patients who are more than 6-8 hours coming within 24 hours. Sometimes we will do this even after 24 hours if the patient has come before 72 hours. So this might help in many of these patients. And if this does not help, then probably there is a kind of irreversible damage to the cavernosal smooth muscles, and they are not totally paralyzed and they are not able to. In that case, we have to resort to some kind of surgical intervention. And the best, there are various types of shunts. There are distal shunts, proximal shunts, Winter shunt, Algorab shunt, T shunt, snake maneuver, all these shunts. The basic principle behind it is the corporal spongiosum and the glans is not involved in Priapism. right? Or it's only the cavernosal bodies. So if you can make a shunt between glans or corpus spongiosum with the cavernosal bodies, it will help to release the blood and cause deturbance. So there are various types of shunt. And there are corporospongiosal shunt, corporoglandular shunt, then we have a corporosaphenous vein shunts. So all these types of shunts. But the best probably in the initial part would be a distal shunt, is a T shunt with a snake maneuver. So snake maneuver is where we just put a kind of a Higgins dilator through the glands into the corporal bodies up to the proximal base of the penis, so that it takes care of the proximal part of the penis. So usually the proximal shunts will not be required if you do a proper T shunt with snake maneuvering, right? And if that doesn't help, then probably no shunt will help. And in that case, he will actually probably require in a later part of penile implant. So penile implants can be done either in the acute phase or later also. Acute phase, sometimes there's a school of thought that once the penis gets fibrosed, the penile implant becomes very difficult after 3 to 6 months. So putting a penile implant in a fibrosed penis is very difficult. So if it is more than 70 hours, 72 hours, you think the priapism is not resolving, then putting a penile implant at that time would be the one of the options available. But again, nowadays, we have another option. So all these shunts probably are almost getting obsolete nowadays. Another is a penoscrotal decompression. So what is penoscrotal decompression? Where what we do, as in penile implant, there's a penoscrotal kind of incision given. And on corporal bodies, you just make an incision on the corporal bodies and then put a suction catheter, suction tube, a pediatric suction tube into the corporal bodies, both on the proximal side and the distal side. And you just suck out all the clotted blood from both corporal bodies. And that can help sometimes to resolve the priapism. And here it can be useful for penile implants also. So wherever you have the incisions that you have been made can also be used to put implants. So that is probably the thing which is coming up now, which probably is the best option available once all the other conservative measures would not help. So thank you, all of you. If you have a question or query, please let me know. Otherwise, we would go to the MCQs. All right, go to the MCQs, please. Okay, thank you. Thank you, Slide. Thank you, Slide. Right. So, yeah. Ask me. Changes the same. Percutaneous. That's what I said about 3 times. 3 times. The penis can get erect after your aspiration and injection of vasoactive drug, whether adrenaline or phenylephrine. You repeat it after again 5-10 minutes, right? So 3 times at least you can do before you think that this is not possible. No. It need not be compressed. It need not be, the root of the penis need not be. There is no need to, because it will even prevent the flow. So what you have to do, you just need to compress the whole penile shaft so that particularly after fistula, when you have made a glandular corporal fistula or a winter or an algorab shunt, to keep the fistula patent, you need to compress it frequently so that the fistula remains patent. Otherwise, it will get blocked easily. And again, the erection will happen. So blocking the root of the penis doesn't help. Yes. So the MCQs. Ischemic priapism is a persistent erection marked by each of the following clinical and pathophysiologic characteristics, except rigidity of corpora cavernosa, bright red corporal blood, hypoxic and acidotic corporal environment, painful rigidity, thrombus within the sinusoidal spaces. Bright red corporal blood. It will be always dark red. So that is the kind of a sign for this priapism. Once the bright red starts coming, that means it is probably in the process of detumescence. Each of the following are etiologies typically associated with ischemic priapism, except sickle cell disease, straddle injury, cocaine use, spider bite, pharmacological erection therapy. Okay, yes. So the straddle injury will cause what type of priapism? It will cause non-ischemic priapism. It can cause the straddle injury, the perineal trauma can result in injury to the penis, corporal bodies, right? So that is non-ischemic. Otherwise, the rest of them can cause ischemic priapism, spider bite, scorpion bite, right? All these have known, even COVID-19, viral infection was known to cause priapism, right? So there are so many other causes for ischemic priapism, which are definitely very uncommon and rare causes, the commonest being intracorporeal injection. After a second session of intracavernous treatment consisting of aspiration irrigation with phenylephrine administration, the priapic penis remains turgid. Cavernosal blood gas results are PO2 40, PCO2 50, pH 7.35. Next step should be observation, oral sympathomimetic, repeat intracavernous treatment, distal surgical shunt, proximal surgical shunt. Yes, I think observation will not help. Oral sympathomimetic will not help at this time. Repeat intracavernous treatment will not help. It already has been done. Or you can at least second session, right? So even one session may also be tried. So distal surgical shunt, right? Is it the normal? It still remains turgid. So PO2 40 is not normal. PCO2 50 is not normal. pH definitely it is slightly becoming normal level, but it has to be 7.4 around. So I don't think the observation should help in such patients. This is not correct. If the penis remains turgid, erect, if you mean turgid by erection, then it should not be. Persistent penile rigidity after a technically successful proximal surgical shunt procedure with a 72-hour episode of ischemic priapism is an indication for observation, gonadotropin-releasing hormone agonist therapy, pudendal artery ligation, distal surgical shunt, penile prosthesis surgery. Right. So observation will not help. Gonadotropin-releasing hormone agonist therapy is only used in particularly stuttering or recurrent priapism, where they think that the nocturnal testosterone level increases. And that testosterone level is responsible for this recurrent priapism. And that is why this LHRH agonist is used. Pudendal artery ligation for only non-ischemic priapism. Distal surgical shunt, no more used. If its proximal doesn't help, penile implant is the option. Priapism associated with sickle cell disease is ischemic. The current pathophysiology is believed to be obstruction of venous flow by sickled erythrocytes, hemolysis and reduced nitric oxide, increased blood viscosity, blood dysphagia associated with reduced reticulocyte count, dysregulated cavernous arterial inflow. So the current pathophysiology, so one of the pathophysiology was sludging of the venous channels, yes, by the sickled erythrocytes. And then the other is, as I said, about the nitric oxide transmitter. So whether is saying B, yes. So something related with the nitric oxide and cyclic GMP pathway. We all know nitric oxide cyclic GMP pathway. So PDE5 inhibitor blocks the cyclic GMP, and that is why the cyclic GMP continues in the blood and maintains the erection. That is why how sildenafil, vardenafil helps, right? So if there is some derangement of that nitric oxide and cyclic GMP pathway, that also is one of the causes for sickle cell priapism or other recurrent priapism. Is it over? Okay. So thank you. If anybody has any kind of a question or comment to make, please let me know. Otherwise, we'll wind up the session. Dr. Ajay, would we like to say anything? Okay. So I would request the moderator to kindly give his last comments and then we'll wind up. Yes.
Thank you, Dr. Karan, for nice presentation, which consists of all important points.
And I would like to thank our guide, esteemed teacher, Shivam sir, for enlightening us all important things and imparting knowledge to us. Thanks.
Thank you. Anybody has any question? Okay. So, of the viewers, I don't think, do you have anything in chat box? I don't think there is any, right? So I don't find anything in the chat box. So thank you everyone, and have a good day. And also, happy Doctor's Day. Thank you, everyone.